Good afternoon, everybody. The time is a couple of minutes past 2 o'clock. My name is Chris Morrow-Frost. I'm the National Clinical Advisor to Hospitals, and I would be normally joined by the rather lovely Pete Gordon, who's the head of ESIST. Unfortunately, this morning he let me know that he's unfortunately poorly. He will be back, but not for this presentation. So I have great pleasure in introducing the lovely Tim Gillett, who many of you will know is a senior improvement manager with the ESIS team. He's going to be in the background and monitoring chat. So this presentation is going to take place over the next 25 minutes or so, where we're going to go through the learning from some of the highest performing trusts on hospital handover delays. There's quite a few slides. We're going to go at pace. We will talk about a couple of case studies in there in the mix as well. But it's just important to set out a couple of things about this presentation. So the presentation itself doesn't recommend anything. What this was a fact-finding piece. We intend to share the practice that we found and then share objectively where we found themes across these 16 organisations that we visited. So don't think that we're going to come to the end of this presentation with a checklist of things that we think you should do or have to do. This is purely an information exercise for you to use. It is evidence-based because it's based on the prevalence of these things in the 16 organisations. Once the presentation's over, we'll take it down, and for the rest of the time there will be an opportunity for any of you to ask any questions. We do have, we're really happy that some of the 16 organisations are on this presentation, so if you've got questions for some of them, then they may feel that they'd like to chip in, and you can put those questions either in the chat or when we finish the presentation, as I say, in about 25 minutes time. So this is hopefully a good, helpful learning event. You'll notice it's been recorded, so you may like to pop your cameras off and your microphones off for the short term until we go for a group discussion later. So without any further ado, let's crack on with the presentation. So what was the 16 visits? So this came as a product of a conversation a few months ago where some senior leaders within NHS England were discussing about some of the concerns that we might be all facing this winter, and ambulance handover delays was in the mix. And there was a discussion around, well, how can we support the NHS to get better and certainly not to slip into any further challenge? And there was discussions around maybe the allocation of resource to the most challenged organisations in the country. But one idea that came to the surface was, is there a possibility of doing something slightly different this year? And so Pete and myself offered, well, why don't we see with an objective open mind, is there something that the people, the organisations, the ICSs that are the most successful in this area, is there something that they can teach us? Is there a magic bullet that will eradicate ambulance handover delays? And so what we need, we got a yes, let's go and do that. That sounds like a sensible approach. So Pete and I contacted the 7 regions and the national operations team, specifically looking at data. In the first place, ambulance handover delays, and in the second place, length of time in the emergency department over 12 hours, to give us a guide as to, well, who is the most successful in the country. What we also used data-wise after that fact was to look at other metrics along the UEC pathway, and you'll see them on bullet number 5 of all the combined data metrics that we used. And you can see at the lower chart there from the SEDIT. If you don't know what the SEDIT is, pop it into the chat, and I'm sure Tim will be able to explain what the SEDIT is. But we used the SEDIT to see if there was a correlation between good ambulance handover delays and other metrics that you would find ordinarily along the UEC pathway focused on the emergency department. And we could see that there was some correlation between some organisations were just good at everything, including ambulance handover delays. But there were organisations that, whilst were very successful with ambulance handover delays, they still were very challenged and struggled in other parts of the pathway. So what that taught us, or told us, was it's possible to mitigate ambulance handover delays while still having challenge across the UEC pathway. We reached out to the 16 organisations and ICSs involved, and we also looked at their SAPIT. If you don't know what the SAPIT is, then pop it in the chat. I'm sure that Tim will be able to describe what the SAPIT is. It's coming to a tableau to you soon. And this is what it looks like. In very, very brief, because it's not a SAPIT teaching session, in brief, this is a RAG-rated look at the whole of the UEC pathway for an acute provider. It's not RAG-rated in terms of good or bad, so red doesn't necessarily mean bad, green doesn't necessarily mean good. It's RAG-rated in relation to where this organisation sits versus other organisations across the country. So if you are red, that means that you are likely in the most challenged quartile in the country, and a nice bold green means that you're in the top. And so we wanted to look at the SAPIT to see where organisations sat across the whole of the UEC pathway. And you can see it reads from left to right, from front door to back door. And we didn't use this necessarily to draw conclusions about each organisation. What we used it was just to itch our brain where each organisation may be being successful or may have challenge in order to be able to feed our judgments. So, in no preferential order, we found around about 25 consistent themes across the 16 organisations. There was only one that was present in all 16, and it's on the screen now, and that's around executive leadership and the feeding into culture. So what we found is everywhere is that staff award, clinical level, shop floor level, describe their executives as feeding and demonstrating the values of their culture, of their organisation. They said that they see their executive leaders on a daily, and if not daily, then definitely a few times a week across a wide range of clinical areas, and that they see them in site meetings. And what we found that was quite moving is that there was emotive language to describe their executives. So they were described consistently as caring, as accessible, as that they listen, and that they give permission and empower staff to do the right thing, but they're there behind and backing staff. And what we also found when we sat down with each of these organisation and ICS executives is the messages the executives gave us around what they will or will not tolerate inside the organisation. We found that the same messages and conversations were being reiterated from healthcare assistants to nurses to junior doctors to admin staff across the whole organisation. So executives setting a tone of what the culture of our organisation was prevalent. So a few case studies, and for each slide we're going to talk about some case studies, is in no preferential order, and we'll try to mix it up for the 16. So Chesterfield, the chief operating officer, worked weekly twilight shifts in her ED. South Warwickshire, the Director of Nursing and COO were present in a participatory sense to their site meetings. Royal Berkshire, all of their executives work shifts, twilight shifts in different clinical areas. Chelsea and Westminster, their medical director is on the rota for their assessment, acute medical assessment unit. Salford, their executives block out days in their diary to go and work in and alongside staff. And Gateshead, their whole executive have back to floor days once a month. So all of the executives spend time with staff, listening to them and seeing patient care happen, whether it is challenged or not, or otherwise. The next theme, again, in no preferential order, is around keeping people in their usual place of residence. So what we found is the majority, these 16 organisations have got joined up services within the ICS, and that comes in the form of many different guises, but fairly consistently, there's care coordination hubs, or the prevalence of call before you convey models. So advisory services either in the community or in the acute sector, in order to keep people at home and be managed still in the community rather than the last stop, getting them to hospital. And what we found is that fairly consistently these 16 organisations enable the ambulance service, particularly paramedics and tech crews out on the road, to easily access physically or virtually services that can provide them with advice, which results in non-conveyance. We found in a couple of these organisations that what they found was helpful is their ambulance service allows access to the ICS, to their stack. And so that means that services within the community and in the acute sector can pull patients off the stack so the ambulance service doesn't need to deal with them, thus reducing the pressure on the ambulance service overall. We found that fairly consistently within the community, services were open, long extended hours, they were very easily accessible, and for the majority there was open access criteria. So not these long inclusion or exclusion lists, but an ethos of, well, just ring us and talk to us and we'll work it through together as to what is the best thing for this patient. We found that acute and community teams providing remote support and advice meant a reduction in conveyance. And also pretty much all of these had very effective UCR teams in place. So a few case studies is that Thameside have something called Digital Health, which we were particularly impressed with. This is an NHS organisation that's based in the community. It's a blended workforce model. And they allow access to any healthcare partner to seek advice. But one aspect that we found particularly interesting that was around about 4 years ago, they gave that their ICS gave every single nursing home, care home and residential home an iPad with which that they could, if they wanted to, if they were thinking of conveying or seeking advice for a resident, they could connect via the iPad with a virtual member of the virtual community service called Digital Health to be able to discuss what they were concerned about. And what they found that since the introduction of that 4 years ago, they've had a significant drop, almost to zero, of inappropriate conveyancing from homes into hospital settings. Walsall, which is an integrated trust, have got an integrated care navigation centre, and what they have found that centre is a blended workforce from across the community and the acute sector, but they've also invited voluntary services in, again, to keep people at home. South Warwickshire, Luton and Dunstable and Bedford have all got something similar to that Consultant Connect service I've described, so that there's an advisory service that any healthcare professional can tap into that may result in a possible conveyance and therefore stopping that conveyance. But if they do have to be conveyed, it's rarely to the emergency department and more often to SDEC or assessment units or frailty units themselves. And then lastly, North Tees stuck out particularly well in that they've got a 24-hour UCR service that has got a SPA, a single point of access hub, that any healthcare professional is able to access at any time. Before I talk about SDEC, is just to remind people that for those of you who've just joined, we're going to do the presentation first, and then the presentation is going to close down, and we're going to open it up to conversations either through the chat or in person. So bear with these slides. So same-day emergency care. So again, not in any professional order, but all of the 16 organisations think it is a complete no-no to bed your SDEC. And so there is consistent executive and clinical protection from bedding a same-day emergency care setting. All of the SDECs within reason are good sized estates, and where they are not, there is executive plans that have been business cases that have been signed off for the expansion of SDEC. And in general, these SDEC services have got capacity for the demand, but there is real insight in the true demand that there is, either virtually or physically, for same-day emergency care. But in general, the access criteria is not inclusive or excluding by nature. There isn't those long lists that I described earlier on within the community setting. They, for all intents and purposes, have open access criteria. And what we mean by that is the clinical leaders of these areas want staff outside in the community and inside the hospitals just to ring me and have a conversation. If you think in your clinical judgment that your patient might be best served by getting advice or coming through my service, I'd rather you just contact me. Let's have a conversation about it. Let's not write a long list of things that you can or can't send me. If you think it's appropriate, then I'm going to listen to you. So there's a real encouragement of partners to ring and just have a conversation. And what this does is that it empowers trust within the ICS, and you see that benefiting patients because patients adhere to the CQC patient first type publication, in that patients are genuinely ending up with either the right care in their own home or the right care in the right place first time. For the majority, the 16 SDECs do offer this telephonic or virtual advisory service. And really importantly is that these 16 SDECs They're not a dumping ground for an overcapacity emergency department. However, there is a spirit of helping the emergency department out. But for the majority, the true essence of what SDEC is supposed to be about, which is avoiding unnecessary admissions, avoiding deconditioning, and getting the right clinician in front of the right patient as early as possible, you find that ethos there. So from a case study point of view, the Homerton that we visited, they've got a very large SDEC area with open access, and any healthcare professional within the community is open to having a conversation with them. Sherwood have got an SDEC village, which they've recently going through the process of doubling in size. It's a nurse-empowered service with nurses taking, for the majority, the calls and advice with medical input and open access criteria. North Tees have got a blended AMU and SDEC village, which 60% of their activity is from referrals from healthcare partners from within the community and the trust. Bedford offer a SDEC virtual advice service, as discussed with other organisations. Chesterfield have a particularly strong SDEC in-reach model, so it's not just waiting for people to refer, they proactively go hunting for patients in the emergency department environment. And although it wasn't one of the ones we had visited, is that we do know about John Radcliffe, who've got an outstandingly good SDEC hub, which is consultant-led with a wide range of community and in-hospital partners that are able to provide advice and or care in the community or in the hospital environment. Inpatient ward processes. So we know the UEC pathway is indeed a pathway. Ambulance handover delays are often a symptom of problems elsewhere. And what we found is that whilst there are some organisations that are troubled by length of stay, is that for the majority, they had good front door and good back door processes. So what does that look like? Well, when we physically visited the wards in these 16 trusts, staff on the wards used this language, which is really important. ED's problems are our problems. Patients having delays in ED, those are our patients, it's our community, we live there, so it's our problem too. We have a duty in the wards to create flow and to support ED, to keep our community safe. That could be my dad, that could be my sister, that could be my child waiting for an ambulance. So why wouldn't I want to help this problem? And we found that in all 16 of these organisations. We found fairly standard processes being used in a ward environment. So we found 100% prevalence of ward and board rounds, things similar to, and in some cases actually safer, the use of safer patient flow bundles, red to green days, and timely and daily senior reviews, both on the board round and on the ward round. But consciously a very strong MDT, empowered nursing, allied healthcare care professionals and administrative staff in a home first culture. And we shouldn't pick anybody above anybody else. But in all of these organisations, the consultants in those ward environments relinquished overall power of a ward round or a board round. And it's them that empowered other members of the team to truly be peers in getting patients home. And we saw that in practice. And we also saw some really good green shoots around clinical criteria for discharge in medicine in these 16 organisations. So a couple of organisations where there was particularly good practice. So Royal Berkshire, they have a supernumerary band 6 coordinator in every ward, and also on top of that a supernumerary ward manager for each ward. And what they've seen then is a consistent and intensive focus on discharges, on the support of board rounds and ward rounds and MDTs and red to green and criteria-led discharge, and also a load of other beneficial effects around retention, morale, adherence to mandatory study, support and one-to-ones and clinical supervision on the wards, etc. And then Gateshead are particularly heavily focused on promoting an MDT approach on wards. They've got very strong whiteboard usage. They adhere to the safer processes, and they have got a particularly strong discharge lounge package where they've put in a pharmacist to be based in the discharge lounge at all times to expedite decision making. Site meetings. So as a past site manager myself, if you see the picture on screen, that's really what the 16 organisations look like. A long time ago from my, in comparison to my clipboard and pieces of paper. But site teams and operational teams have got access to live dashboards and live information, and not just inside the hospital. We found that ICSs generally are much more joined up in live information, risk dashboards that are all inputted on a live basis, so that ops teams have got live and valid information at their fingertips. Mostly the site meetings themselves were virtual. They no longer seem to be done in presence. And what we did find is that there were war and peace of people attending. So there was significant divisional management and clinical representation across the hospital, and actually in the majority of cases from the ICS as well. We found pretty much universally that directors or executives were present, but they didn't dictate. They were just part of the team. And for the majority, were prepared to roll up their sleeves and just get involved. And if they did have a role, it was to empower a collaborative response to the challenge of the day. We found strong clinical presence in site meetings and in ops working generally. So clinicians, particularly medical leaders, were empowered and encouraged to be part of what is the path of least harm today? How do we get through today together? And so what we found is those site meetings were structured, they were risk focused, and they were very proactive in trying to find the actions of today. And there was close looping back on how do we feed back the results of our actions. But medical colleagues generally were engaged with early, and for the majority of the organisations, the 16, what we found is that medics, if they weren't engaged with consistently already, then they were pulled in around about an OPAL level 3, OPAL 3 level to manage that risk piece. So Luton and Dunstable have got a very large electronic room like you've got pictured there, but their clinical and divisional leaders and executives were present in their site team in order to feed that collaborative response. And Royal Berkshire, they actually have a director of the day model. So the director of the day clears their diary and sits in site for the whole day. They're also on call. EPRR supports the site team, and specifically they've got a risk dashboard which shares all live RAG rated risk across the entire ICS, so the ICS can make judgments about whose risk is greater than who else's and how that can be balanced everywhere. And interestingly, at Royal Berkshire, transport sits underneath the site team. So specialty inreach, this isn't just about specialties going to ED and working, although it does include that. What we found is that there was evidence of specialties going to the emergency department to proactively review their own patients, but as well as those sitting in the ED queue. So particularly around times of challenging or crowding, specialities responded to the emergency department. And again, we found the same similar kind of ward language, but what it's not them and us, this is all of our patients. And if ED sinks, we sink. And our patients end up with worse up care. So why wouldn't we support our colleagues in ED, and why wouldn't we want the best for our patients? What specifically was interesting, though, around specialty culture in these 16 organisations is the specialities want to get their hands on patients as early as possible. And so for the majority, nurses and teams who stream in ED are empowered to pick up the phone and speak to them. If you in your clinical judgment have got a patient stood in front of you that you think I, as a specialty clinician, am the best person to see this patient, I want you to ring me and let's have a conversation about it. And for the majority, the conversation ends up with a yes, send them to my specialty receiving area. And there is also a very strong belief in adherence to internal professional standards, and that again was executive and clinical executive led. So Chesterfield, specialties go to ED and take from the stack, particularly at times of crowding. South Warwickshire have again got a culture of take from the stack, and that's a response to operational challenge. Luton and Dunstable have got medicine, cardiology and frailty based in ED, where they're taking patients the moment they see that they're appropriate for them, so that ED doesn't need to work them up. And for the majority, they try and get them home from ED rather than going into a bedded area. And North Tees, all of the medical specialties work up work some PA time. I'll say this again because I've messed it up. In North Tees, all medical specialities have got allocated PA time to work in ED. That's a strong clinical push from one of the clinical leaders in that organisation. But what they believe is that that enhances the culture of we're in this together, and to walk in other people's shoes to understand the pressure that they're under. trust was quite prevalent and important. So we found that there was evidence of a community of trust across the ICS. And so it's a little bit what I mentioned around streaming, is that staff generally across all of these ICSs are empowered to use their clinical decision-making skills. So if you think you've got a patient and that I am the best person to see this patient, I'm not going to second guess you. You're clearly reaching out to me and I believe you're competent, so I'm going to trust you. And so I might give you advice about how to keep that patient where they are. However, that's not going to end up in a ping-ponging of patients, and it's not going to end up in a no. I'm either going to accept that, or I'm going to accept the patient, or I'm going to give you advice on what to do with the patient to discharge them or keep them home. Or I will signpost you to the best person for that patient. And this stems from a strong senior clinical leadership empowerment of this value. It starts with the medical director and filters down to their generals, to the clinical divisional leads. But patients generally are accepted on faith. There isn't a written document that we found. It's more a feeding of a generic culture. So North Bristol, we went to, there was very, very strong senior clinical engagement in fostering a culture of we're in this together, how do we solve our problems together? Tameside, there was exec-led empowerment. And so where there are hiccups between individuals, where this culture wasn't adhered to, executives take it upon themselves to go and meet with the individuals concerned to discuss, well, help me to understand that. Let's get this right together. And for the majority, the hiccups don't happen again. And West Middlesex, they have got a culture that's fostered by the medical director and the clinical leads, again, around we. The medical director is the one who spent a lot of time on a weekly basis in the AMU doing shifts. And so it is a role modeling in the culture that they want. System working. So what we found, so it was difficult for us to be able to physically visit the ICS because, of course, what is it? It's a large combination of things. But we did spend, for the majority of times, virtually visit system partners. And we met them when we physically went to the hospital. And what was really palpable when we sat at these tables with executives and leaders from across the system is that these are people who spend a lot of time with each other. They don't meet once a month at a board. These are people who talk to each other on a daily basis. They finished each other's sentences. They had shared visions and values. They understood what each of their own pressures were. They didn't have to excuse or articulate because everybody understood. And they also shared a common risk oversight and a common understanding of what they were trying to achieve. And we don't say this with any judgment, but what we did find is that a number of the 16 were integrated trusts that was interested, around about half of them were. But these leaders, it wasn't them and us. We never heard that terminology of them and us. It was only we're in it together. So Tameside, their digital health team, I've talked to you about their contact with the nursing homes, residential care homes, but digital health also, interestingly, sit in streaming. So they conduct streaming in ED. And what they have found is that 45, since they started this process, which was a trial, they've redirected 45% of total activity going to ED, either home or into community services. Or to community UTCs. Salford, they interestingly, and when we did these visits, it was quite funny actually, because what is innovative to us may not be innovative to these trusts because they've been doing it for ages, but it's only through these visits that we find these things. So Salford, 95% of the nursing homes, residential homes and care homes are all under one GP service, one GP practice. And so you can imagine the beneficial effects of the trust and the ICS being able to engage with one GP practice for 95% of homes. And then Milton Keynes, they've got a home first team that's based in ED who proactively pull patients and discharge them. They've got a roving frailty team out in the community and who also comes into the acute. And also their ambulance service, SCAS, has got access to MyDOS, which enables ambulance personnel to look at and access any service within the community. So colocated UTCs or equivalent came up. It can be a contentious subject, but these organisations cited to us that it was critical to have a UTC or equivalent co-located to their ED that decants all of the minors stuff, the stuff that could be seen by EMPs or GPs, to a different estate that's not ED. They found that helped in not overcrowding their emergency department and enabled their staff to, for the majority, focus on the more acute and emergency. They saw upwards of around about 50% of total activity. They were open between 16 and 24 hours a day. And interestingly, their UTCs had access to any diagnostic they want. The hospital granted them that. Tameside was interesting in that they not only had GPs and EMPs working there, but they had ACPs, physios, and also surgery and ortho were based in there too, presumably to keep their minor trauma stuff up. Walsall are moving from a 23-hour to hopefully a 24-hour UTC co-located model, and their UTC sees any patient that would have been seen that could be seen in primary care setting, or any patient that could be seen by their advancing competency EMP workforce. And then Sherwood, they stream 60% of their total activity to their GP EMP model that's co-located. So comms and ops, there are other companies out there, but a couple of the organisations used something called Voicera, which is like a lapel communications device, a bit like Star Trek. You tap it and anybody else wearing one of those you can communicate instantly with. But for the majority, these organisations use WhatsApp with different groups of people. And there was proactive and effective and immediate escalation and definitions of actions that were fed to key people. And then those key people fed back the reactions of the actions that they'd been given. So there was that feedback loop. So Gateshead and Tameside were the ones that particularly used Voicera. But yeah, interestingly, Tameside also used their WhatsApp group, which was clinically led with operationals input, at times a great challenge. And so for one example, they used their WhatsApp group when they had lacked capacity in wards, they would ask all of their clinical leaders to revisit their not medically fit for discharge decisions. And they saw that with effect, and clinicians would feedback on that WhatsApp group the decisions that they had made. So halos, some of the trusts don't have halos and they don't need them. And their reason for that is, well, we don't have queues, so why would we need a halo? But some of these organisations do sometimes get difficulties with queuing or challenging from ambulance activity. And what they say is that halo is integral to managing the relationship between the ambulance service and the hospital. They encourage their halos to bring stories from the community where delays have hideously bad effects on patients and on community staff workers, but also they encourage their own staff when they tend to use alternative conveyancing models, pathways, fit to sit. But the ones that do have halo, they say that halos are integral to maintaining strong relationships. So Milton Keynes, their halo is encouraged to write papers for their board and to do presentations to staff in hospitals around the ramifications of delays. And Bedford, their halo particularly has been strong on educating ambulance staff on fit to sit. What was really clear is that emergency departments are not the only place. That's a cultural thing within these ICSs and these hospitals. But specifically, the ICS is making great steps in trying to build alternatives, both in the community and on the hospital site to ED. We're long gone the opportunity that ED is everything and always. Now we need to have multiple entry points in the community and into the hospital to manage the demand that is on the NHS. And that comes about through strong navigation, streaming and signposting, both in the community through SPA model types, but also in hospital. So enabling streamers and navigators to be able to signpost easily with open access criteria patients to different parts of the hospital. And really importantly, for the majority, ambulance staff have got just as much access to these doorways as any other healthcare provider inside the hospital or inside the community. So the Homerton have got a strong ICS links with LAS to build ambulance accessible doorways. And so what they have found is that by a strong ICS push on what does LAS have access to, has seen a drop in conveyance for the Homerton. Chelsea and Westminster and West Middlesex have got a borough action plan for all partners related to healthcare. And one of those interventions, one of those 6 interventions they're focusing on, is reducing frailty conveyancing to hospitals. Sherwood are doubling the size of their SDEC in order to make sure that there is a feeding of capacity versus the demand. Milton Keynes are building, it should be open, if not open, it's nearly open, a huge brand new SDEC village that is in an estate separate to the hospital estate. It's just over the car park road. And then Walsall again are moving towards that 24-hour UTC. Redirection. We found redirection was a thing. It's a bit of a dirty word, but redirection is probably something that's going to be very important over the next 1 to 2 to 5 years within the NHS. And we have to empower staff to make confident and competent decisions around getting the patient to the right place. And that might not be on the hospital estate. So some of these organisations, they all do it differently. There wasn't a consistency, but the ones who do redirect, which is around about 11 out of the 16, they do that either by empowering senior people at triage, senior nurses as navigators, encouraging all walk-ins to use the 111 telephones in the waiting room, and some of them use electronic digital solutions like an iPad or etc. North Bristol was one of the organisations that encouraged walk-ins to use 111, and Thameside obviously have got that digital health solution sitting and streaming. So AMUs, we found that for the majority of these 16, AMUs were big, and often they were blended. So they were AMUs, bedded, trolleyed, chaired, SDEC combination areas. We found that there was a single point of access. So there was one person that you could connect with on behalf of medicine, and that person would then signpost which of the many areas within medicine that patient could go to, and it wasn't by default AMU. The length of stay we found for the majority was between 24 and 48 hours, and the executive maintained and backed AMU to do that. The language that they used was, if AMU goes over 48 hours, then we're stuffing medicine, and that will then stuff ED. We found there was very strong clinical leaders who foster a multidisciplinary team culture within AMUs. And actually, when it came down to leaders, in all of these 16 organisations, goodness me, you would want the nurse and the doctor leaders in those areas to work for you. They were dripping in strong character types that were beneficial to patients. There was patient-first language dripping out of them. They were dynamic, they were driven, passionate, pragmatic, and they were diligent in championing. We need to make sure that we function efficiently so that we can provide the best service for our patients. So North Bristol have got a 64-bedded AMU, which enables ambulance access. 50% of their bed capacity is cubicles, and all medicine is referred directly to them. It doesn't sit in ED, and if they need to, they double occupancy their cubicles there. Royal Berkshire have got a 24-hour length of stay for their AMU, and it's also a blended SDEC environment up to 92 spaces. Gateshead have got 24-hour length of stay for their AMU, and it's all cubicles, 48 cubicles. And North Tees have got a 24-hour length of stay, and they've got a blended, flexible areas that they have for AMU, for SDEC, etc. And that adds up to around about 84 spaces. FCPs. So everybody in the NHS has got an FCP, but we felt for the majority, these 16, their FCP meant something. It had meaningful actions with strong articulation about how they were going to escalate and de-escalate. And we also found that for the majority, clinicians had signed up to the creation of these FCPs. And so everybody understood nobody wants to go to extremists, but if we have to, these are the steps in order, and these are the people that should be involved in the decision making of what is the path of least harm today. So for 6 out of the 16, they board or do some kind of boarding. All of the 16 do not differentiate between the language of boarding and corridor care. They all say it's the same thing, so why would we talk about it differently? If we say we don't board in here, then we also mean we don't corridor care in ED. That's quite powerful stuff. For the 10 that don't do any kind of boarding or corridor care, our obvious question was, well, how do you do that? And they say the solution is through collaboration. If we during the day can spot the signs that things are getting tricky, we pull everybody together. There's a strong clinical and operational response where we decide together what is the right thing to do based on the challenges of today, based on the risk that we can see, so that we never have to board. And the trick is they do that at 10 or 11 o'clock in the morning, not at 7 or 8 o'clock at night. Effective full capacity protocols were generally clinically and executive led. And also, as I've said there's an executive culture. It starts with the execs of, we don't corridor care in this organisation because it's unsafe. So we need to work together on doing this together. Half of them do RAT or pit stops, the other half do zonal care. So what I mean by that is a receiving area that's often nurse-led to turn around the handover of patients coming in by ambulance. Half of them do that, and so there's a rapid assessment, diagnostic and treatment and diagnosis process for those patients. But for the other half, they do zonal care. So a band 6 or a band 7 senior nurse receives the ambulance patient. They direct them to one cubicle in one of the zones in ED, and the patient stays there and is looked after by the same nurse and by the same doctor for the duration of their care. But really importantly, ambulance receiving nurses are empowered to stream patients to anywhere inside or outside of the organisation based on their clinical decision making. Fit to sit. Most of them had dedicated large fit to sit areas, and this was integrated either into the emergency department or was part of their same day emergency care offer. They were large, they were often nurse led, and there was a culture generally of patients need to sit unless we can absolutely clinically articulate why this patient has to be looked after on a trolley. So they say that that results in a lack of automation of care, because if we see patients lying on a trolley, we're more likely to put a cannula in them, we're more likely to do an ECG, we're more likely to do bloods, we're more likely to do A, B, C, D, E. But if someone's sitting down, we're more likely to concentrate on what does this person actually need. And there was a culture of communicating across all sorts of workforces that lying people down causes deconditioning, and we don't want to do that. And also fit to sit didn't start at the front door. An end there is that fit to sit was made all the way through the patient's journey, even to a ward level. Can we sit this patient out? And therefore we should. One organisation that particularly comes to mind for fit to sit was Bedford, who've got a very, very high bar in regards to what you need to have wrong with you in order to be looked after on a trolley. And so they have got a huge fit to sit estate and SOP. Streaming, I've already touched upon, and we're nearly at the end of this presentation now. Streaming, in all of these organisations, people are just empowered to get the patient to the right place at the right time. And specialities, services and estates are open to that kind of contact. And for the majority of these organisations are streaming upwards of 60% of their total ED activity away from ED. And there is a cultural acceptance that this is the right way to work. It's easy to get in contact with the specialty services. It's easy to transfer them across. And in some cases like Walsall, they don't even speak, they just do it electronically because there's an acceptance of competency by those streaming nurses. But overall in these 16, there is a high level of cultural trust around nursing competency in order to make that decision. So this last slide here is a few bulleted observations about other things that cropped up. So the regular use of information in order to feed ICSs and organisations. And so a good example of that would probably be Salford. Sorry, not Salford, Derbyshire. So Derbyshire audit all pathways that the ambulance service have got access to, and they audit how many patients end up going down that pathway. And where they see low adherence, they have got a working group that goes and speaks to the service and to the ambulance service around why is this not used as much as it is, with an improvement mind or methodology of improving that in the long run. The use of live and visual information to enable all teams to see the hospital at a glance. We've seen that used, in particularly North Bristol had got an excellent risk management live dashboard across their ICS, so they could see where the greatest risk lies at any one particular point. Emergency department flow coordinators. So Chesterfield have got a supernumerary admin person that only focuses on what are my patients waiting for. Personal patients plans in the community. So that was the Salford one. So you can imagine dealing with one GP surgery for 95% of residential nursing and care home patients is going to be super useful in being able to liaise on the creation of meaningful patient plans and where it's working and not working. Virtual wards, Royal Berkshire have got a triumvirate management team that's specific just to virtual wards. That's what they look at. Emergency department rounding. So Gateshead have got hourly rounding that not only looks at care factors of patients that are sitting in the department, but also asks the question, what is this patient waiting for and is it being done soon? Growing and modernising workforces, these 16 are focusing on what's the new workforce of tomorrow to fill the gap of today. And so of particular note is Royal Berkshire, who are growing a massive ACP and physician associate workforce. Hot clinics, South Warwickshire particularly enables ED to access any hot clinics that they think is appropriate in order to avoid admissions, and front door frailty processes and teams. That was particularly evident in places like Royal Berkshire and South Warwickshire again for their Consultant Connect. So that is the presentation over and done with. I'm going to appear on screen. We haven't got a huge amount of time, I don't think, for questions, but I'm going to pause the presentation there. Tim, I can see you've appeared on screen as well. Oh, I wasn't on camera. I am now. So yeah, how did the chat go? And if you want to ask a question, stick your hand up, please.
Brilliant, thanks, Chris. There's not an awful lot in the chat, but while people can catch the breath, I'll ask a question if I may, just to start us off. There was an awful lot of examples there. You were littering it with the examples, and I could see, and I was taking down notes of, oh, Chesterfield's doing that, or South Tees or North Tees is doing that, or whatever. Is there going to be something that comes out like a compendium of what different places do? How would people find out more about those things?
Yeah, absolutely. Thanks, Tim. It's almost like we might have had a conversation about this, and I promise you we haven't.
We didn't.
No, we haven't. The loud feedback that I'm feeding, that Pete and I are feeding back into NHS England is that you, for the majority, know what to do. And you don't need to be told what to do. Actually, for the majority of organisations, you want to know how have other people achieved the what. And so the case study piece is really important, and that's something that's being talked specifically about a lot in NHS England this week. Pete and I have put our heads together, and Tim, I'm very sorry that I might be the person to tell you this, but Pete has said that he's going to kindly ask the ESIST guys to see if we can't pull together a compendium of the case studies. So little bite-sized pieces, whether that's a one paragraph, a 250 word something, a 1 minute video, something that's palpable but bite-sized for you guys with busy working lives to be able to dip into something that you have interest in. But also, if you have got a specific interest in anything that's come up on the presentation, stick it on the chat, because Tim or I will answer anything that's in the chat after this is gone.
Brilliant, thanks, Chris. And Sarah from Salisbury's put that in, that asking for a list of the providers. I think that will go down well if we can pull that together, and it always, doesn't it? People, as you say, most people know the what, but understanding the how and learning from people's journeys is really, really important. I'll open it up then. Are there any other questions? Anything anybody wants to ask Chris?
And whilst people are thinking about sticking their hand up, I can see there are people from the 16 on this call. So you don't have to ask me a question. You can ask questions of those people as well if you want to.
Absolutely. So pop your hand up if you've got a question. This is the bit where I normally try and fill until somebody answers, but I'm going to go quiet and put the pressure on everyone on the call to do that. So please ask us a question.
I mean, Tim, oh, no,
here we go. We've got
one. Anything. I don't have to say anything.
Brilliant. No, we've got two here. Let me just do it in the right order. It's two familiar faces to me. So Jyoti and then Joe. Jyoti, over to you. Hi.
Hi, good afternoon, everybody. I'm sure you know the answer to this. I just want you to spell it out. What it is what I'm hearing loud and clear from from many trusts is, and also from the STEC STEC teams, basically, that co-located STECs seem to be proving very, very successful. Especially the specialty ones. Now, in these 16 organizations, did you have any such theme coming up? Because especially co-located adjacent to a ward, really the workforce issues are quite significant now. And the co-located STECs really lend themselves to having that flexible workforce. And so you can keep them open longer, with just a small increase in the workforce rather than needing a whole load of workforce if it's in a different place. And also it stops the safari ward rounds. So just any theme on that?
Yeah, so well, Jyoti, your SDEC was one of the areas that we visited, wasn't it? So you might already know a lot of the answers to that yourself. But I'm cautious not to make too many recommendations because this is about sharing what we found. But in the spirit of that, what we found is that the SDECs, they were prevalent. So they were there, they were co-located and they were accessible. They were manned by clinical and nursing leaders that were open to conversations. They were also open for good amounts of time that fit the demand of when patients are coming or when patients need support. And for the majority, SDECs had found their own bespoke way of offering something that didn't rely on just in-house. So there was something around being able to virtually offer the same level of support and advice without the patient needing to be brought to them. I think if I was going to answer your question just in one sentence, I'd say, Jyoti, it felt like in these 16 organisations, for the majority, the SDEC environments were really developing insight into what kind of service does my hospital and ICS need, not what kind of service do I think I want to offer. And so it was flexing workforce, it was flexing access criteria, it was flexing accessibility to what is the demand of our organisation. Does that answer it?
Yeah, it's mainly for those new organizations who are thinking of building SDECs and thinking of a new estate for their SDECs. So what's the best advice we can give them going forward? That's the reason I was asking.
Jyoti, you are the national clinical lead for UEC. You also happen to work in one of the top 16 organisations in the country. Do you think that co-located SDECs are a good thing?
I personally think if I was setting out to do something new, brand new, that's what I would do. I think the way you can actually flex the workforce is really, I think it does lend itself to better working conditions if you have a co-located SDEC, especially for specialties.
Thanks, Jyoti.
That's my personal answer.
Thanks, Jyoti. Let's go over to Joe Halliwell from Mid Yorkshire. Good to see you,
Hi,
Joe.
Tim. Hiya. I've got a question about, you referenced in one of the case studies some of the audit work that you'd done around alternative pathways and where they weren't being used in the way that they'd been anticipated to be used, or getting the bigger beneficial benefit out of that. I am really aware of the fact that there is such considerable inconsistency that our ambulance trust colleagues have to work with in multiple different places and organisations. So what was it that came out of that audit? And are there almost like a top 10 of recommended pathways that has been evidenced to have the biggest beneficial impact in terms of community care provision?
Okay, so I don't think I'm going to be able to come up with the top 10 in a couple of minutes off the top of my head. And I don't want to blag either. I think it's important you get the right answer. So Derbyshire was the place that said this. There's a guy called Dan Webster, who's the one who fed back on this. And I think the spirit of it is that they looked at what is not being used effectively, and that was numbers driven. And then they, as a working group, which was an ICS working group from different parties, looked at, well, would we expect more activity along this particular pathway, especially if we look at our attendances to the ED of certain codes. And then they went back and used that as a way of, let's have a conversation with our ambulance partners and our service provision partners. But if you want me to, Joe, stick your thing in a chat and I'll introduce you to Dan.
Fantastic, thank you.
Brilliant, thanks, Joe. James, over to you.
Thanks, Tim. Thanks, Chris. That was a really good presentation. I really enjoyed it. The most obvious, and this is really obvious, observation is that most of the solutions from all of those trusts were actually external to the ED. They were all involving the trust as a whole, supporting the leadership team, the exec, etc. And it really demonstrated where thinking outside of ED, the solution is outside of ED. And so when you get together with when you get those points put into a little sort of recipe book, in terms of these are the really big things that really made a difference to these trusts. I think it'd be a good thing to be able to deliver to our COOs and CMOs, etc. To say, this is why these are the top 16 trusts in ambulance handover, because often, I know it sounds really obvious, but they often just always look at ED as, come on guys, you've got to sort this out. And it really isn't in our gift, which is, I think, a lot of this presentation demonstrated. And the in-reach stuff, so as well as in-reach into the ED from specialties is absolutely brilliant, but also in-reach from the community. So hearing that there's trusts that have community in-reach teams as well, pull patients out, I think that's absolutely vital. And linking all those things together will be really, really good. So really looking forward to the next stage and keen to get involved in collating that information.
Well, I'm taking that as an offer, James. But James, you obviously work in John Radcliffe, which has got an outstandingly good SDEC provision, and particularly in that outreach advisory element. So I'm with you, is that these 16 organisations, if it wasn't implicit in the presentation, this is about decanting one part of the UEC pathway to enable more patients to survive and get the care they need.
Brilliant, thank
I think
you.
we've probably got time for one more.
Yeah, just that one more, Chris, from Anwar. Hi there, Anwar from Northern Lincolnshire and Goole. What's your question for Chris?
Hi, it's a comment and a question, and that is that, if you look at it, generally the principle is the same. People are trying to develop everything they can within urgent emergency care within the hospital, but also integrating what's available outside. And I mean, the previous caller actually made, James made the summary of that, is that there is a lot more that needs to be done in the access to the services that are outside. There are available services, but are they accessible? So kind of in our patch as well. And there are so many forums, you'll sit and you talk about this is available, this is available. They're not accessible. And that's the bit, I think. And it's a surprise that in all over the NHS, in the whole country, there's so much variation based on individuals and teams that have made the difference, rather than it being a generalized standard of service that is required in that area for. So the difficulty of the ambulance services that was posed earlier on by one of our colleagues from Mid Yorks was because ambulance trusts provide input to a bigger area, and they have various trusts in those areas, and all of those trusts and the community services have different services. So what we need to work towards in regions is standardization mainly of what's available, so that it's the same DOS for the whole bit rather than different. Now, it may be variable way of providing it according to the population requirement, but at least similar level of service. And that's what we need to promote. So there is a lot that, for example, NLAG is doing, our trust is doing in terms of STEC and UCS. We push towards, getting our UCS 24/7 and need support for that. But there's a lot of that clinicians and teams think that is the correct thing to do. But then again, to push it to be, holistically taken as accepted services in the region, that's the bit that's difficult.
Thanks, Anwar. I'm conscious of time, and we're now making people late. But I think if I was going to answer in short, I think the key is partners talking with each other, and that might mean talking to other ICSs, that might mean talking to other regions, but it's about are we truly getting to the bottom of what's the best thing for the patient? And part of that is talking to people in the ambulance world to say, how is it for you, for your whole catch, and is there something we can collectively do together? Yeah, all right, so Tim and I will look at the chat after this. It's now finished. Thank you for joining. There's 2 other versions of this, so you don't need to come to another one unless you want to, but feel free to forward the invite to others. That's on the 19th and the 20th, and put in the chat if you haven't got the links to those. But thank you for coming, and I hope that was useful. Thanks, everybody. Bye-bye. Thanks.
Thank you, everyone. Bye-bye.